Hi there, good afternoon everyone. As Dr. Heaney said, my name is Shannon. I'm one of the Endocrinology Fellows, and I'd like to just tell you about patient AD today. He's a 25-year-old male who was complaining of 2 weeks of vision loss, which was quite dramatic, which manifested in ways such as being unable to read half of the street signs when he was driving on the freeway. He was then evaluated by ophthalmology, who requested an MRI, which subsequently discovered a pituitary tumor. Review of systems, patient denied headaches, loss of libido, galactorrhea, or fatigue. Social history is notable for a history of frequent marijuana use. The exam in the clinic office revealed decreased visual acuity with loss of peripheral vision just grossly bilaterally, somewhat worse on the right than on the left. He had no stigmata of Cushing's disease or acromegaly, but he did also have notable gynecomastia bilaterally. So this is a picture of his marked gynecomastia. As you can see along the lateral edges of his chest, there is indeed a significant gathering of breast tissue, which to palpation was not simply fatty tissue, but was actual breast tissue. So here's a few pieces of information that came back, some laboratory data that came back a few days subsequent. The dilutional prolactin was 23.8. So just a slightly elevated prolactin level outside the normal range. A 4 p.m. cortisol was 5. Thyroid stimulating hormone 0.67 with free T4 of 1.2, both within the normal limits. And at the time, pending insulin growth factor 1, testosterone, and ACTH.
So what you see on these visual fields are obviously, as our arbitrary sort of look goes, we set these fields up so that you're looking as if the patient's looking out from his eyes. So this one on the right here, this is sort of an irregular arrow. On the right is the right eye, temporal, nasal, and the left eye, temporal, nasal. And these obviously have dense bitemporal visual field cuts that run right down the midline. So, I mean, to us, this would be localizing to the chiasm. I mean, there's not really much else that would do that. The ones that don't marginate so well on the vertical midline might be something else. So some of the ones that extend across, particularly in the supratemporal region, that could be because the tumor is growing bigger and getting the non-crossing fibers. But more likely, when these things don't line up like that, it's some other kind of optic neuropathy. But in this particular case, where they're like this, pretty much that's a standard chiasmal visual field defect pattern. So, to me, a couple of questions with this case. One question was the speed of the visual loss and how you would manage it based on the speed. For us, if it's a couple of weeks, is pretty fast for us. Most chiasmal tumors that we see, the visual loss is progressive over months or longer. So a couple of weeks of visual loss could either mean that there has really been a rapid visual loss, which means possibly rapid expansion of the tumor and possibly a bleed, or something that had been present and the patient didn't know about it, wasn't paying attention to it, and then the visual field gradually got more toward the center, and then they noticed a rapid visual field loss. But for us, 2 weeks is pretty fast for that. The other findings that you might expect on a case like this, and again, I'll remind you that I didn't see this case, so you know. We would look for evidence of optic nerve malfunction, which would be, in addition to the visual fields, visual acuity loss. That may or may not happen, though, depending on where exactly the field loss is. So in these, where it kind of runs right down the middle like this, the other half of the field is intact, and it usually is completely intact, so that they can read perfectly well in the field that's there. So this patient probably was able to, if you tested him, see 20/20 on the chart in this half. So he might read half of the visual acuity line and then stop. So we look at acuity, we look at the fields, we look at color vision, and we look at pupillary findings. And the pupillary findings are often important in a case like this. And they can be difficult because in something like this where there is symmetric loss, you might expect the pupil findings to be abnormal, the pupils to be sluggishly reactive to light. But our standard sort of optic neuropathy pupil finding is the so-called afferent pupillary defect, or the Marcus gun pupil, and that requires some asymmetry between the two pupils. So you see one pupil that reacts much better than the other, and it has this sort of paradoxical appearance where you shine the light back and forth, and it looks like the light you're shining into the pupil actually makes the pupil dilate on that swinging flashlight test. For something like this, where they're equal, you might not see that, but you might see sluggish reactivity on both pupils. So it can be a little tricky here for this. And then the final thing we look at is the fundus appearance, to look at what the optic nerves show. And it could be anything. In an early stage, if this was really a recent loss and no loss preceding that, you could have these visual field defects and still have optic discs that look normal in the early phase. And that would, of course, be a good prognostic feature for that patient to get recovery. On the other hand, if it's been a long-standing case and they just noticed something recently, they may be pale optic nerves, and that would be a worse prognosis, obviously. So that's kind of the stuff that we look at for a case like this. Any other
what
questions?
specific tests should we, if we see a patient who we suspect has visual field loss, should we order a Humphrey's? Can you tell us about the different?
Yeah, so this is a Humphrey quantitative static perimetry test, which is kind of the thing that we use most frequently to evaluate the defects and to follow. This is a pretty detailed test. I always tell people who don't look at these very often that they're not testing all these little dots in here. These are the points that are tested, and then this is a computer interpolation, which sometimes is misleading. So we actually look more at these numbers, believe it or not, than the nice pictures that represent it. So this is the best one. Go ahead.
What do those numbers represent? We see somebody maybe with, instead of a 20 in there, it's 40. What's that?
Yeah, I would say if you're not looking at fields a lot, then the actual numbers are not that valuable because you don't see it that often. But these probability plots are nice. These are actually, these tables here are differences from normal. So there are age-corrected normal data points for each one of these. And these plots are tests of how far away from normal it is. So that's kind of an easy way. If these are -10 or -20, it shows you the depth of defect away from normal. And this probability plot actually tells you the statistical probability that that will not occur by random chance. So the black squares mean that there's a very small random chance that it's going to be abnormal. So the black squares are the more abnormal things. So rather than looking at this, which is kind of hard to interpret unless you really look at it a lot, these data points are the easiest. So to recap that, this is the one we use most often, and there are a lot of screening perimeters out there that are kind of good just for that. If there's a huge defect like this one would probably be picked up on most of them. But if you're asking for something to really quantify what's going on, this is the best thing to order. There are Goldman kinetic perimeters that was the standard for many years, but it's very hard to get technicians to do those anymore. We almost don't even have it at the institute here, which is one of the major centers. Yes,
So another question that comes up, I mean, what is the urgency? So it's like you were describing, if you see optic atrophy, that indicates a degree of longevity in the process. If we see someone like this with this kind of, appearance and a short history, I mean, is there somebody that needs to go to the OR in 24 hours, 48 hours, 3 days? I mean, how sensitive is the nerve to pressure?
Yeah, that's a tough question to answer. For the most part, if it's recent and again, part of it is how much that chiasm being distorted. I mean, you asked about how big the tumor was. Another issue is, of course, how far it's being distorted. But for the most part, if the disc looks good, you don't have to rush into that. That's not going to disappear within a few days. You can do that within weeks. We would say, without significant chance of losing a lot of vision. But there's no hard and fast rule for that, obviously.
Because this patient was telling us that, every 2 days he could track that his vision was getting worse.
Yeah. So that must be, well, it was a big tumor. You said it was a big tumor.
Yeah.
I mean, you would have to expect that there's a lot of chiasmal distortion to be doing that. But even the ones, again, there's no way to really predict what's going to happen aside from, for us, from looking at the disc. But even the ones that get to a really bad visual point, when they get decompressed, they come back if the nerves look good. So that's the reason I said that, is that even if they've gone severely downhill over the first week, if you can get it decompressed, most of the time that's going to come back.
Okay, I don't want to hog all the questions, but what's the typical duration of recovery? Because I'm thinking of a young man we had recently who did see some improvement, but still has significant, drop off.
Visual recovery after decompression. Yeah. Well, as I'm sure you know, most of the ones that are going to come back reverse right away. Within a day or two, they start getting a lot better. And then the usual recovery time to get to the end point is 3 to 6 months. But again, you can usually see that right away. I'm sure that's what you see.